Welcome from a very chilly Bangalore. As I'm based in Bangalore, I'm Dr. Mohd Akmal Ariff, graduated from Government Dental College in 1994. And then I started practicing implant from 2010, and I'm into this field from past 15 years. It's been a very long journey in the field of implantology. And as you are sitting there 15 years back, I was sitting and listening to what implant was. As far as my knowledge goes, when I was doing my B.D.S, we never heard about the word implant. But you people, the younger generation, are lucky enough to start knowing about implants during your undergraduate itself. Even though implantology is a vast field, but gaining the knowledge of it is very, very important. Because in the world today, because of the Google and all the social media, the awareness among the patient regarding the implantology has shooted up like anything. So when the patient visits you in your clinic, you should be knowledgeable and you should be well aware about what an implant is and how you can convince the patient to take up the treatment of implantology in your clinic. And if you're not aware, and if the patient asks, you'll be cutting a sorry figure in front of the patient, which is not acceptable in the modern field nowadays. So knowing about implantology is very, very important. So my basic plan will be to, in this next 2 days, that is today 45 minutes and tomorrow 45 minutes, is just give you an overview about what implant is and what are the things you have to look into when you have to select the case, and how will you come to a conclusion about the diagnosis of the diagnosis and the treatment planning of the case. So my intention would be to make you aware about what an implant is, how will you select the case, how will you convince the patient to go in for an implant, and how you will manage the cases. So today I'll be just concentrating on the case selection, diagnosis, various types of implants available in the market, and I'll be explaining you a brief about the varied cases. And tomorrow I'll be going into detail about the prosthetic components, how the prosthetic will be taken place, what are the different types of processes you'll be giving to the patient, and then something about immediate loading and different types of loading. And I'll be giving a brief about some amount of complication and how to manage them. And if at all, if you want to go forward in the field of implantology, we have various programs in Osstem where we'll be conducting the basic master course, where you will be trained under well-known clinicians, and you will be given a brief about what an implantology is in detail, and then you will be placing the implants under the guidance of the well-known, renowned clinicians. You will be placing the implants and you'll be restoring them. And we have various programs in Osstem, like the basic course, the advanced courses, where they'll be teaching about the sinus lift, wrist split, and all the other complicated cases and complex cases can also be treated. So we have various type of programs, and who all are interested, tomorrow in the last slide, I'll be giving you about the brief about whom to contact and how should you go about in learning the implantology. And as always, I start my talk by saying that in dental practice, we have something called as ABC. The same thing holds good in the field of implantology. ABC, as you all are aware, we started our education by learning A, B, and C. So A stands for the availability. So whenever I give an appointment to a patient, particularly in the field of implant dentistry, I should be sure that I am there in the clinic at least 15 to half an hour minutes before the patient comes and sits on the chair. And make sure everything is in place before you start doing the procedure. And the most important thing in implant dentistry is to taking the informed consent of the patient. So taking the informed consent of the patient as well as the relative of the patient is very, very important in the field of implant dentistry. B stands for my behavior. How is my behavior towards the patient, towards the relatives of the patients who are accompanying them? So it plays a very, very important role. My behavior should be to the mark. My behavior should be very, very good towards the patient. And what does C stand for? C stands for the competency. How competent enough I am to handle this particular case? Am I competent enough? If not, let me join the courses which will make me competent. Let me learn. There's no age to learning. The age is only for becoming old. But when it comes for the learning process, there is no age. I remember teaching a doctor who was a dean of the college. He was around 55 years old, and he just came into our program to learn what implant dentistry is. So there is no age, and there shouldn't be any barrier as well. So to gain the knowledge, you have to become yourself competent enough, have the knowledge about what you are doing, and then proceed with the case. So let me start briefly with this, and then I'll go ahead. Some of these slides I might go forward because I have a very short time of 45 minutes to 1 hour, and I would like you to stop or keep the questions at the end so that I can answer your queries. If yes, I'll proceed further. So I think most of you are aware about what an implant is. So I need not have to define what an implant is. And if most of you are from Partha Dental, and I know you people are placing a lot of implant in your clinics, and I hope to see you people who are not placing the implant, join the programs, get yourself competent enough, and then start placing the implants in your clinics. So that will be my intention, to see to it that you start placing in your clinics. So what is case selection? Case selection is the systemic evaluation of patients, the site where you want to place the implant, and the prosthetic factors to determine the stability, the predictability, and the long-term success of the dental implant therapy. And I keep on repeating this, all cases are not for implants. So your case selection is very, 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 very important. Don't land into trouble in just placing the implant in all sort of positions, in all sort of angulations, and when it comes for the prosthetic session, you're not able to restore it. What is the point in placing an implant in the places where you can't restore it? So planning, and before that, case selection is very, very, very important. So whenever you select the case, make sure you select the perfect case. And I'll just be going slowly how to select the cases, what are the things you have to look into, and how you should proceed. And then tomorrow we'll be going to brief about the surgical phase and the prosthetic phase and different types of implants where you can use, where we'll be using the immediately loading, immediate extraction placement implants, what type of implants you want to use. And if it is a delayed the implant placement, what type of implant you want to use. We'll be just briefing it. And as I told you, I keep on repeating it. If you want to gain the knowledge and become competent enough, join the courses which are very, very helpful for you and which will give you the knowledge so that you can have the competency to handle all type of cases. As I keep on repeating again to my students previously and now today also, whenever you start the case, start with plan A and plan B. Okay. Now, what are the things you have to look for when you are planning a case? How will you want to select the case? Patient-related factors. What are the patient-related factors you want to look for? First and foremost, age. Do you want to place an implant in a patient who is 8 years age or 10 years of old or 11 years old? No. There's a definite age the lower age limit for the girls is from 14 to 16 years old, so that when the jaw has totally grown, and in boys, it is around 18 to 20 years old. If you place the implant in the patients younger than 12 or 13 in girls, there are chances there might be malocclusion, malalignment of the implant, because the jaw keeps growing, whereas implant becomes stagnant over there. It gets osseointegrated and it doesn't have any movement. Whereas when the jaw grows, the other teeth will start growing, coming down, whereas this teeth, the implanted crown, will stay at a place and it will give an awkward look. And if you're doing this case in an anterior region, aesthetically, it will look very, 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 very bad. So the first and foremost is the age relation. So if you want to place an implant, place an implant who is above 16 years old in girls and anything above 18 to 20 in boys. The upper limit is no limit. We have placed implants in the patients who are 94 years old, that too full mouth, and they are doing very well from past 5 to 6 years. So there is no age limit. For the upper age limit is not there, but the lower age limit, it is 14 to 16 for the girls and 18 to 20 for the boys. How can I know if the growth has taken place? You can take the wrist X-ray. You can take this cervical spine X-ray and find out if the growth has taken place before you proceed with placing the implant. So the most important factor is the age factor, and then comes the systemic health. Is the patient diabetic? If he is diabetic, what is HbA1c? What level of HbA1c is comfortable for me to place an implant? Anything below 7 is very, very comfortable. We have placed implants in the cases where the HbA1c is 8.5 also, and we have seen a very good results. But only thing is, we might have to leave instead of 2 months, 3 months in the lower jaw, and probably 1 or 2 months extra in the upper jaw to allow it to heal better and get osseointegrated. But never do immediate loading in diabetic patients. Okay? And then, what happens if the patient is on bisphosphonates? What is happening if the patient is osteoporosis? Am I able to place this implant? No. You should be very careful in selecting. Analyze the systemic diseases of the patient. Then only you proceed. So, and then what are the other things you have to take into consideration? Is the patient uncontrolled diabetes? Absolutely don't fall into trouble. Don't put the implants in the patients who are having uncontrolled diabetes and land into problem. Because you are taking the decision. The patient doesn't know whether he can go in for implantology or not. But you are the one who is going to take the decision. So make sure that you select the case which is ideal enough and then proceed. And then what else? Smoking. Smoking. What happens in smoking? The healing is reduced. Increased failure rate. What happens? There is vasoconstriction. The healing phase gets prolonged. And if the patient is a chain smoker, kindly don't place implant in that case. The implant will gradually fail. It will not integrate at all. And you will be telling to the patient that the implant is a permanent procedure. And when you see the implant failing, you'll be cutting a sorry figure in front of the patient. So make sure that this patient at least stops smoking 15 to 20 days before you place the implant, and at least 1 month after placing the implant. And make sure he gradually reduces the smoking habits. This is very, very, very important. And what happens in osteoporosis? You can't place the implant in patients who are suffering from osteoporosis. Why? The bone becomes very brittle. They are prone for fractures. So in osteoporosis, you are not supposed to place. So the patients who are on osteoporosis are put up on bisphosphonates, which again is a contraindication, because bisphosphonates will not help in osseointegration of the implant to the bone. So you should be very, very careful when you are selecting the cases. And what about the radiotherapy? What will happen if the patient has undergone chemotherapy, chemoradiation? How long should I wait? Can I place the implant immediately if the patient has undergone chemotherapy 1 month back, chemoradiation 1 month back? No, you have to wait for a period of 6 months to 1 year. So once the patient has undergone radiation therapy, you have to wait for 6 months to 1 year to help the patient in restoring the oral teeth by implants for at least 6 months to 1 year. And then what else? Immunocompromised patient. What happens in immunocompromised patients? High failure risk. The implant will not take up, it will not get integrated. And the patients are on long-term steroids. Again, the immune system is compromised. So you should be very, very, very careful when you're selecting the cases. Okay? And then what happens to oral hygiene? If the patient is not maintaining any oral hygiene, there's no point in placing an implant. When the patient cannot maintain his natural teeth, what guarantee you will have that the patient will maintain the implant teeth? Just for the sake of making money, don't push the implant into the patients who are maintaining a very, very, very bad oral hygiene. There will be a lot of problem if you are not able to convince the patient to maintain the oral hygiene. So if the patient has lost his or her teeth because of a very bad perio and very bad oral hygiene, make sure you explain to them in detail how the oral hygiene is to be maintained so that when you place the implant, it remains in the patient's mouth for a longer period of time. If not, the peri-implantitis and all sorts of complication will happen, and ultimately the implant will come out and there will be failure. Then what else? You have to motivate the patient to maintain the oral hygiene and have a follow-up every 6 months, or initially for first month, then 3 months, and then every 6 months you have to follow up the case to see if how the patient is maintaining his implant. So these are the few things which are patient related. And then what are the site related factors? The site related factors are very, very, very important. What is the amount? What is the type of bone I'm coming across? What is the quantity of the bone available? What is the height of the bone available? How can I assess this? By IOPA, by OPG, by CBCT, by CT. So these are some of the diagnostic tools, or X-rays and diagnostic tools just gives you the findings, but they don't give you the diagnosis. Make sure don't diagnose a case by just seeing the X-ray. X-ray just gives you the findings and it doesn't help you see, let it be CBCT or CT, it doesn't help you in telling about the quality of the bone. You can just see the trabeculation. The quality of the bone is measured by Hounsfield units. So if at all, if you want to know the quality of the bone, you have to go for bone density test, which will help you in knowing the Hounsfield units. And then you can decide whether it is a dense bone, is a trabecular bone, or it is very loose trabecular bone. So depending upon that, you can decide. Anatomical limitations. What am I looking at? Anatomical limitations. Wow, where exactly is the floor of the sinus? Where exactly is the interfallar nerve? Where is the mandibular canal? Where is the mental foramen? And how long is the anterior loop coming out? So you have to be aware about the anatomy when you are doing the lower jaw as well as the upper jaw. Where is the nasal floor? Where is the incisive papilla? Where is the incisive canal? So you should be aware about the anatomy of the maxilla and the mandible thoroughly before you start the cases. And most importantly, when you're doing in the posterior, in the 7 region, lower 7 region, the mandibular, submandibular fossa. If you're not aware about the submandibular fossa, you'll be penetrating and perforating the lingual plate. So how should I place the implant? So knowing about the anatomy of the maxilla and mandible is very, very, very important. And what about the soft tissue concentration? How is the biotype? Is it thick or thin? I should be aware about it. What should I do if it is thin? If it is thick, well and good, good keratinized tissue, I can go ahead. What about if the keratinized tissue is not there? How can I increase the keratinized tissue? By modifying the incision during the stage 1 or stage 2, or else by doing the free gingival graft or connective tissue graft. Because the soft tissue is very, very, very important for the success of the implant. You might have placed the implant in the bone, but what will happen if there is there is no soft tissue drape around the implant. There will be subsequent peri-implantitis and eventually the implant will fail. So you should make sure that around the implant, you have a very, very good soft tissue with a very good keratinized gingiva. Otherwise, your implant will fail. Studies have shown that lack of keratinized tissue around the implant will result in implant failure. Eventually, the implant will fail and it will come on your hand. That is what I'm telling you. So planning a case and selecting a case is very, very, very important. If you select the case, your life becomes easy. Don't rush into placing implant in all the cases. All cases are not for implants. So I keep repeating this. Tomorrow when I start the section, I'll be starting with a case where I'll be showing you the X-ray and I want you to diagnose for 2 minutes before I start with the section tomorrow. Okay? And what are the bone quantity? The bone quality, you have misclassification. Like you have dense bone in division A, then moderately dense bone, and then trabecular bone, and then you have very severely deficient bone. So accordingly, you can decide. But I believe in seeing the bone, feeling it, and then coming to a conclusion whether it's a dense bone or soft bone. So there are different classifications we have. We have Lacombe and Zapp classification for the quantity, for the quality of the bone, like it is dense cortical, then thick cortical, then thin cortical, and very porous trabeculae. So this classification is very, very difficult to analyze or diagnose, find the findings in the CBCT or this thing. Only once you open the flap, visualize the bone, feel it, only then we will come to know whether it is a dense bone or a porous bone. Then what anatomical limitation, as I told you, there are various, and then the soft tissue, as I told you, the biotype, whether it is thick or thin, and then whether it is keratinized tissue is there or not, and then the vestibular depth. Again, the very, very important thing. If there is no vestibule, how will you restore the teeth? So there are surgeries where we can increase the vestibular depth. So I have to take care of the vestibular depth. If I'm doing a full arch, if there is no vestibule, the patient will have problem. He will have soreness once you place the implant on the crowns. So you should be careful enough, or else correct that. Correct the vestibular depth, increase the vestibular depth by doing the surgery, and then go ahead. Then what are the prosthetic considerations? What type of prosthesis I'm giving to the patient? Is it a screw retained? Is it a cement retained? It is a single crown, or is it a fixed partial? Or am I going full arch, all on 4? So you should decide in beforehand. I believe that according to my experience, implant dentistry is the prosthetically driven with a surgical component. Placing an implant is not a rocket science. Anybody can place an implant. But when it comes for restoring is the real challenge. So if you plan your case prosthetically before you start, your life becomes easy. Regarding when to decide whether it is a screw retained, cement retained, I'll give a brief tomorrow when I'm going through the prosthetic phase, prosthetic components, and how we'll decide whether it is screw retained or cement retained, or it is a hybrid bridge, or it is a full arch, whether you want to go for old denture, whether you want to go fixed for the full arch. That I'll give you the brief how to calculate about it. But as I told you, these are the salient features which you have to take into consideration when you're selecting the case. And what about the occlusal factors? Do you want to place an implant who is a bruxer? In the patient who is a bruxism, who is having bruxism, who is having clenching of the teeth, all your ceramic will keep chipping out. The abutment screws will be getting loosened. We have seen cases where there's a fracture at the neck of the implant because of the bruxism. So selection of the case is very, very important. Don't rush into placing implant into the patients who are having parafunctional habits. Okay? Make sure that habit is broken. Give them the night guards. Give them the splints. Make sure that not a lot of force is not exerted on the implants. Otherwise, there will be constant fracture of the ceramic around the crown, abutment fractures, and then abutment screw fractures. And then ultimately we have seen cases where a fracture of the neck of the implant. So we have to retrieve that implant, redo the implant. So a lot of issues will happen. So selection of selection of cases is very, very important. And what are the aesthetic demands when it comes to the anterior teeth? It's very, very, very challenging to select the case. Is the soft tissue sufficient enough? Or should I add the pink gingiva? So make a mock-up of that case before you start proceeding with the placement of the implant. And explain to the patient what you're doing, particularly if you're doing the aesthetic demands. Explain to him what are the shortcomings you might come across. Don't say, I'll give you the best of the treatment. It will look like a natural teeth. The gingiva will be very, very fine and you'll be very happy. I can give you best. Don't tell that. We'll try to do our best. But there are some shortcomings, particularly in the aesthetic zone. If there is buccal plate loss is there. If the soft tissue problem has happened over there because of long standing edentullism. So when it comes for the aesthetic zone, explain to the patient everything in detail so that he'll be ready. So don't fall into complications, say this has happened and it is very difficult to rectify it. So when you take the informed consent with the patient, make sure everything is explained to them in detail. Then what are the surgical factors? When do you want to place the implant? Whether you want to immediately place after extracting the teeth, that is immediate extraction and placement, or whether you want to do an early implant placement, that is when the soft tissue healing period is going on, or we want to delay it. Delay it in the sense, allow the socket to heal for 2 to 3 months, allow the bone to mature, and then you can open the flap and then place the implant. That is delayed implant placement. Then immediate implant placement, you are extracting the teeth and placing the implant. I will show you some of the cases tomorrow where we have immediately extracted the teeth, placed the implant and immediately loaded it, particularly in the anterior region. I'll show you some of the cases. So today I'll be just briefing you about the case selection, diagnosis, and the various type of implant, and then various type of cases. Whereas tomorrow I'll be totally showing you the clinical cases from start to end, and then I'll be briefing you about the different type of prosthetic components, abutments, how to select the abutments, everything in detail. Okay, and then need for adjunct procedure. What do you mean by this? Should I do any GBR, guided bone regeneration? In this case, if there is deficiency of bone, should I do sinus lift? Should I do wrist split? These are some of the advanced techniques. So it comes in surgical factors. So timing and the need for various adjunctive procedures like sinus grafting, GBR. If the ridge is very, very thin, should I do a wrist split or ridge expansion? So everything is to be decided beforehand. And what are the risk assessment models? What is SAC classification? SAC classification S stands for straightforward case. An ideal implantology case with ideal anatomy, non-smoker, everything is falling in place. You can straight away decide and start placing the implant. What does A stand for? Advanced. There are some of the things where there is moderately complications are there. So you might have to do some amount of GBR, some amount of modification, and then place. And what does C stand for? Complex cases. What do you mean by complex cases? There's high risk and you might require some specialist care. You might have to take help of the doctors who are well aware about how to manage these cases. Okay? Don't feel shy. I remember a case I did in the anterior region where the gum was very, very bad and I was not well versed in soft tissue grafting that time. So I had to take the support of the doctor who was well versed in it, and the result was very, very fine. So you shouldn't be shy. You shouldn't feel shy at all to take help of the seniors or the doctors who are well versed in some of the procedures which you are not able to perform. It is for the good of the patient. And what are the contraindications? What are the contraindications for the implant placement? As I told you, uncontrolled systemic diabetes. If there is an active infection in the area where you want to place the implant, avoid it. Allow the infection to settle down before you place the implant. Then, poor patient compliance. If the patient is not cooperative, there's no point in placing the implant. As I told you, poor oral hygiene, don't place the implant. If the patient is not able to manage his natural teeth, what guarantee you have that he'll maintain his artificial teeth which are placing with all the efforts and the money of the patient? So don't rush just for the sake of making money in placing the implant. Case selection is very, 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 very important. So, and what are the relative contraindications? As I told you, smokers, bruxers, and then reduced bone volume. When does this reduced bone volume happen? Long-standing edentulation cases. There's no height of bone. There's no width of bone. Don't place the implant. No doubt, today we have advanced techniques where we place zygoma implants, pterygoid implants, and transnasal implants. But am I competent enough in doing those cases? I have just started placing zygomas and pterygoids. But how comfortable am I? Unless and until you place more than 500 to 1,000 regular implants, don't rush into placing zygomas and pterygoids and falling into place. It's our advanced techniques. Okay? Now then, proceeding ahead. So, ideal implant case, how should it be? The patient should be healthy patient, non-smoker, adequate bone volume and quality, favorable occlusion, and high patient motivation. So these are the factors which will help you in selecting the cases. As I told you, if the patient is having is a controlled diabetic, you can go ahead. But in uncontrolled diabetic, no. No in patients who is on long-standing steroids, who are on bisphosphonates. Smokers, you can motivate them to stop smoking for the sake of placing the implant and gradually help them out in stop the smoking. So, and then motivation of the patient to maintain the oral hygiene. They are spending a lot of money on this. Motivate them. Make sure that their money doesn't go waste. And then favorable occlusion, as I told you. Bruxers, constant fractures. Some patient, over-eruption of the teeth. You're not able to place a crown. Do an selective endo on the opposing teeth. Create an occlusal plane, and then proceed further. So some of the modifications, you might have to do some of the cases to place an implant and restore it. Don't place an implant in the places where you can't restore it. What is the fun in just placing the implant if you're not able to restore it? Okay. So as I told you, the flow would be, so finally it is the decision making. So the patient evaluation, medical risk assessment, radiographic analysis, prosthetic planning, surgical feasibility, and the patient consent. If all these factors are good enough, you have selected the best of the cases and you can start proceeding, placing the implants. If, as I told you, if one of the factors is not feasible, make sure if he is uncontrolled diabetic, make sure his diabetes is under control and then proceed with the treatment. If the patient is on antihypertensive drugs, which drugs will affect what way? So everything is taken into consideration. If the patient is on long-standing steroid therapy. So case history is very, 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 very important. So don't come to a conclusion. Let me start placing the implant just by seeing an X-ray and then just for the sake of making money. So case selection is very, very important. If you succeed in selecting a perfect case, your life becomes easy. Otherwise, your life will become hell. Because you're charging a very, very hefty amount for implant. And as I tell you every time, Once you place an implant in a patient, you are married with him for the life. Even a small movement of the crown or a small irritation, he keeps calling you, sir, you had told that the implant is a permanent procedure. I feel the crown is shaking, and you have told that the crown will not shake. It will not come out. How is it coming out? So these are some of the things you should be aware. So make sure you keep the patient informed about everything before you start placing the implant. Okay. Now proceeding further with the diagnosis. So successful implant therapy depends on accurate diagnosis, prosthetically driven treatment planning, rather than surgical skill alone. As I told you, anybody can place an implant, but the real challenge is when it comes for the prosthetic phase. I'll show you some of the cases tomorrow, which were referred from the other clinics, and the implants were placed in the worst of the angulation, and we are not able to restore it. How we corrected it, I'll show 1 or 2 cases of that type as well. Okay, proceeding further. Patient evaluation, medical history. What am I looking into medical history? Everything in detail. Then what about the dental history? What am I looking in the dental history part of it? See, when you come to dental history, why has the patient lost that particular tooth? Was it decayed? Was it periodontally involved? What was the cause for the loss of the teeth? Evaluate why the patient had lost the teeth and the duration of edentulation. How long that site has been without the teeth. What happens if it is a long-standing edentulation? There is supra-eruption of the opposite teeth. There is severe loss of bone. So everything is to be considered when you take the dental history. And then if the patient had undergone the previous implant and whether he's happy with the implants or if there was any failure of the implants. So, and then as usual, I keep on repeating parafunctional habits. By just looking at the occlusal surface of the teeth, you can say whether the patient is a brusher or not. So analyze when you take the dental history, everything in detail, the perio problem, the pocket formation, how far the pockets are happening, how is the adjacent teeth. If the adjacent teeth is not healthy enough, you will be risking your implant. So make sure everything is fine before you start placing the implant. Do a thorough oral prophylaxis. If required, do a root planing. Make sure the adjacent teeth are healthy enough before you start proceeding. And what are the extraoral examination you are looking for? The lip line. Then the smile line. Whether the facial asymmetry is there. So everything you have to take into consideration when you are planning. And what is the vertical dimension? Is the vertical dimension okay? Is there is loss of vertical dimension? Is the occlusion okay? So everything has to be analyzed when you do the extraoral and intraoral examination. Then oral hygiene status of the patient, the periodontal health, the mucosal condition, then the interoral space. Depending upon the interoral space, you can decide about the type of processes you want to give. And then the opposing dentition. Is the opposing dentition good enough? Will it take up the load when the patient starts eating the food? So everything is to be taken into consideration when you proceed further. What is site-specific diagnosis? Again, the repetition, the bone quantity, quality, rich morphology. Is it knife edge rich? What should I do? Should I do a moment of crystalloplasty? Should I do alveoplasty before proceeding in placing the implant? So you have to plan it accordingly. The CBCT helps you in knowing the anatomy of the ridge beforehand. So you can decide how much of bone should I reduce, how much of alveoplasty should I do. You get a very good bone at the crestal level and soft tissue assessment. So everything has to be taken into consideration, whether it is thick biotype, thin biotype, keratinized tissue, vestibular, how deep is the vestibular, everything is to be consideration. Okay. And then proceeding further, radiographic evaluation. Radiograph just gives you the findings. They don't give you the diagnosis. So depending upon the clinical symptoms and signs and the findings which you have in the radiograph, you can decide. In the field of implantology, IOPA, RVG, it gives you a two-dimensional picture. It doesn't give a three-dimensional picture, but with RVG and IOPA, you can roughly assess the height of the bone. How much of height of bone is available. OPG for analyzing the various anatomical structures. Where exactly is the floor of the sinus? Where exactly is the nasal floor? Where exactly is the infraocular canal? Where exactly is the mental foramen? So everything you can analyze in an OPG. But OPG will have some amount of what? Either elongation or shortening. So it doesn't give a one-to-one effect. So you should be very careful. So OPG is just for studying the anatomical structures or any pathology which is there. So it gives you just the findings. CBCT, precise enough. So you'll know what is the width is a three-dimensional picture. So it will give you the width, height, length, everything can be assessed. Mucodistally, how much of bone available. Then buccolingually, and from the crest of the ridge to the anatomical structure, how much of bone available, everything can be assessed. CT again is a very good diagnostic tool to find the width, height, the density and everything. And then with CT, you can plan your guided surgeries. So in guided, if you want to do guided surgery, CT is the best radiographic tool you can use. CBCT, not much, but I would prefer if you're going for a guided surgery, go for CT rather than CBCT. Okay. Then what are the treatment accord? Let us just brief about what's happening in a single tooth, in multiple tooth edentulosum, and then full arches. So treatment according to tooth loss conditions. So if the patient has lost the anterior teeth, you're not competent enough to place an implant. So you will give an RPD or an FPD. So what happens when you give an FPD? You are sacrificing the adjacent natural tooth. You're removing the enamel, the vital structure of the tooth, you are removing it. So you are sacrificing the tooth. This is how you should convince the patient to go for an implant. Explain to him what happens if you're doing a bridge. What happens if you give an RPD? So explain to him so that you can convince him to go for an implant. So you will be prepping the adjacent teeth for a bridge. So what happens again in the subsequent long run? Secondary decay, periodontal involvement of the teeth which you have taken support of, and subsequent loss of that teeth as well. And then you end up sacrificing another teeth, which was good enough before you place the bridge. So implantology plays a very, very important role in maintaining the natural teeth to the core. So make sure when you start explaining to the patient about the treatment options available for edentulosum, whether it is a single tooth, multiple tooth, or full arch, what are the advantages of the implants? Only then the patient will understand. No doubt they might have Googled it, but rather than Googling it, if it comes out from a very, very deep doctor or an experienced doctor, if he explains to them in detail, the patient will get convinced. So you should explain in such a way that patient should get convinced to go in for an implant. So you'll be landing in a lot of problems. Bridge. If you are competent enough, you'll be saving the adjacent teeth. You'll be maintaining the naturality. You'll be placing the implant and restoring it. And what happens in multiple tooth loss? 2 or 3 teeth are missing. You give an RPD, the teeth on which the clasp is there will start becoming loose, and eventually you'll be losing that teeth as well because of the shear forces on that particular teeth. So make sure you explain to this all the complications or the disadvantages of an RPD to the patient, and then you can convince him for an implant. So you end up placing 2 implants, restoring it with 3 crowns, so that there will not be. And what about the full arch cases? You can go for over dentures depending upon the inter-arch space, or else you can go in for full arch cases, fixed processes, hybrid, hollow bridges. So different type of prosthetic options you have for full arch. If the patient is financially not good enough, you can give him a CD in the upper arch and a 2 implant ball over denture or locator implant denture for the patient, so that, as you all are aware, the most problem in CDA happens in the lower jaw because of the tongue and the thin ridge. So if you can stabilize that denture with 2 implants, the patient will be very, very happy, so that they can eat the food comfortably without the movement of the denture. Or else, if the patient is financially good enough, you can go for all on 4 or 6 implants and give a fixed prosthesis. This is bar denture, and this is 78 implants, and then giving a fixed PFM. So single teeth, adjacent teeth preparation is the biggest problem or the disadvantage. The masticating activity also gets reduced. So by placing an implant, you are helping the patient in maintaining the naturally the adjacent teeth, and you are giving him the best of the treatment. So your options should be implant oriented. I know it's a good way of making money, but selection of the case is very, very important. Don't jump into placing implant in all the cases. Okay. One of the clinical case where you can see the right side, the bridge was given, and then when we removed it, we saw that it was endodontically involved. So we had to do the root canal treatment, upright that teeth, give a single implant, a single crown for those teeth, and then squeeze in an implant and restore it. And look, see how good that looks. And they are all individual crowns. And the patient is very happy in eating the food. He is feeling comfortable. That is what they have come for. So planning a case and executing is very, very important. Some of the cases you might have to do ortho treatment as well, endo treatment as well, perio treatment as well. So don't treat the site of edentulosum as a case of implantology. You have to take care of all the teeth before you start placing the implant. Am I clear till now? So, and then these are some of the cases, our mentors. So what is the overview of the implant? So implant, a compound word of implant. So imp means inside and plant is to place. So what is a dental implant? Artificial processes which is biocompatible inserted into the alveolar bone to support the one-sided, one design to restore and replace the missing teeth. So it is acting as a root where you will be placing an abutment to hold the processes. So these are a rough definition about what an implant is. And there are history going on where in the ancient area, in the ancient era, implants were used where they used the ivory teeth and the stone as the implant teeth. So implant dentistry is not modern technique. It is there from a very, very ancient period. And in the Middle Ages, they used to re-implant the teeth. Very rich people, they have lost the teeth. He used to get his teeth re-implanted from a donor. So this was there. Allogenic tooth transplantation. Natural teeth extracted from the poor people to be transplanted to the rich. This was there in a very long, this was also there for a very long period. And then the evolution of implants. Pranama, the person who is responsible for dental implantology. He was an orthopedic surgeon. He's not a dentist. He's an orthopedic surgeon who accidentally came across the osseointegration of titanium plates, which he had placed in the rabbit femur to understand the blood circulation. So the osseointegration of titanium implant was an accidental discovery by Brannemark. So there is a very big history, which itself is a very long lecture for 1 or 2 hours, where the different types of implants are evaluated over a period of time. So depending upon the implant placement position, we can classify it as endosseous, transmandibular, and subperiosteal. And most of the days, nowadays, we are doing only the endosseous implants. And sometimes we are planning for subperiosteal, where there is massive resorption of the ridge. We can plan for customized subperiosteal implants. Okay. And then depending upon the type, we have a screw type, cylindrical, and the blade type. And then metal or porcelain. In porcelain, we have zirconia implants. And metal, we have titanium zirconia alloy, and then gold alloy. And most of the times, the best metal is the titanium. Why? So let me brief that to you. Okay. So classification, we have the subperiosteal here, and then we have the transmandibular and the endosseous. Endosseous, we have the blade type, and then the endosseous implant, regular conventional implants. So type of modern implants. Let me just go first with this. If you want to understand all this concept in details, you have to enroll for the basic implant program of Osstem company, so that it will be a course of 6 days to 7 days, where you will be taught in detail about the anatomy, the physiology, the blood supply, the nerve supply, how the surgical protocols to be followed, how to go about with the placement of the implant, how to restore it. All the things will be taught in detail in the program. And it's not costly also. So types of, again, let me just brush through this. Transmandibular implants. And then we have the modern implants, the blade implants, and the endosseous implants, cylindrical or the screw type. And this again, the evolution, how the implant started and how they, over a period of time, there was different discoveries done by different doctors. So the current dental implants are the Brannemark type implants. So these are the different type, external hex and the internal hex and main implant system. This and all will go into detail in the basic program. Now we are just short of time. I'll just brush through this. Okay. And the person responsible for the implant, as I told you, the concept introduced by Professor Brannemark, an orthopedic surgeon at Lund University, Sweden in 1952. Brannemark inserted a titanium cylinder into the leg bone of a rabbit to study the healing process of bone. After the experiment, Brannemark tried to remove the titanium cylinder and he was not able to remove it. It had osseointegrated. That is how the word osseointegration came into picture. Okay. And osseointegration of implant is very, very important for the success of implant. So this is the how it looks microscopically when the implant is osseointegrated. So what are the 6 main factors affecting the osseointegration? The biocompatibility of the material, implant design, the surface coating, the bone conditions at the surgical site, the surgical procedure, and the load conditions. Whether you are loading it immediately, whether you are loading it early or delayed. That I'll be briefing you about tomorrow. So the factors that interfere with osseointegration: traumatic surgery, low healing potential, implant movement during the placement, overloading, poor implant biocompatibility, and surface impurities. So the implant should be sterile enough when you're placing it. So the properties and conditions of biocompatibility, all of you know about this. So let me not go into detail of this. So what are the materials? Biomaterials used for surgical implants: titanium, titanium alloy, cobalt alloy, that is cobalt, chromium, and molybdenum, zirconia, and tantalum. So the tantalum and the zirconia implants are still under a lot of research is going on in that field, so that we'll come across a massive search for the zirconia implants in future, particularly for the anterior, where the zirconia implant will not give a gray hue on the gum if the surface of the implant is exposed to the soft tissue. So these are some of the things. So if it is unalloyed, we grade it to 1 to 4. And if it is a alloy, we have titanium, 6 aluminum, and 4 palladium. That increases the strength. That is grade 5. Okay. And most of the implants of grade 1, grade 2, and grade 4, and whereas the abutment and the various prosthetic components are of grade 5 for the strength purpose. So titanium alloy, this tensile strength is good, whereas biocompatibility is good in grades, grade 1, 2, and 3, and 4. So grade 4 is the strongest implant, and grade 5 usually use it for abutments and the various prosthetic components. This again is a type of cobalt chromium molybdenum. We use it in NP alloy, cast abutment. Then we have the zirconia, but see, you can just see the difference. If it is a metallic, it gives a gray hue sometimes. That can be overcome by the zirconia implant. But how far it gets also integrated is a big question mark. There's still the investigation, the evaluation is going on this, the research is going on. So very soon, we'll come to know how effective this zirconia crowns will be. So tantalum, again, another material which can be used in oral implants. It's similar to platinum, stronger and cheaper than platinum. It was widely used in early spiral implant, but nowadays, most of the implants are of titanium. Let me just brush through this. These are the various systems available in Osstem, the TS system, KS system, SS system, US and MS system. And these are the various type of grades we used. So usually if it is a thinner implant or a smaller diameter implant, we use a grade 5 to increase the strength. And if the diameter of the implant is pretty good enough, we use the grade 4 or grade 3 sometimes, but very rarely. So most of the implants are of grade 4. And if you are thinner implants, we use grade 5, that is titanium alloy, to increase the strength, particularly at the neck of the implant. So what are the implant types? One body type and two body type. What do you understand by the one body type and two body type? One body type, the abutment is attached. It is a single piece implant. So you can't retrieve the abutment. It's a single piece implant. So what are the pros? Fewer post-surgery concerns. Screw loosening is not there because it is a single piece. It's synced down, so placement becomes easy. Micro movement to some extent, but it can be avoided. What are the cons? Limited prosthetic options. If there is an angulation error, you can't correct it. You can't place the processes. So you can't do stage 2. So you have to immediately load it. So inability to remove the implant if it is osseointegrated. So you have to use a refine to remove the implant. So where you will be using a lot of bone when you use the refine. So narrow bridge implant, denture implants, and the provisional implants are single piece implants. And then we have the two type where we have various types of prosthetic options like the regular stock abutments. Then we have multi-unit abutments. Then we have angulated abutments where the abutments get attached to the implant with an abutment screw. Okay. So two types. What are the pros? Compatible with various prosthetic options. Two-stage surgery possible. And remote tool can minimize alveolar bone loss. So failures are less. Process must be retightened to address sink down. So that is only disadvantage we have. So history of surface. So again, it is a very vast subject of surface coating. Let us just brush through this. Now newer techniques are available where the surface coating will help you in getting a very good initial primary stability and very good osseointegrations. And then we have some biologicals also used. And then the classification of the body type. We have the straight type, taper and taper. And then we have parallel implants as well, straight body implants. So depending upon the design, you can decide which implant in which place you want to use. Okay. So selection of the case and then planning it is very, very important. So these are the external connections, external connection implant, where you'll be placing the abutment over it. And then these are the internal connection abutment implants, where the implant will, the abutment will get locked. So let just me press this. I think I'm almost all done with 1 hour from the time I started. This